Now we have the case on pediatrics now. So may I call Dr. Shatarupa Mukherjee to moderate this session, and I will call Dr. Shubhadeep Das and Dr. Sananda Banerjee Mukherjee to join the panel, please. Thank you.
Good evening, everyone. So, thank you ICCM Howrah for giving me us the opportunity to present. We'll be doing a case-based discussion on a child admitted to the cardiac critical care unit of our hospital. So, as we know, malnutrition at PICU admission is quite frequent. It's almost 15 to 25% in developing countries, and this malnutrition is directly related to increased morbidity as fever, infection, weakness, prolonged mechanical ventilations, and delayed recovery, as well as increased mortality. So to begin with, we had a 1-month-old baby girl, similar. The birth weight was 2.6 kilos, but the current weight was 2.3 kilos when she came to us. She was diagnosed with transposition of great arteries with a ventricular septal defect. Referred from a district hospital, admitted in that hospital since birth. She was formula fed. There was history of sepsis and NEC at day 10 of life, treated with antibiotics. She was referred to us for cardiac evaluation and early surgical intervention. So my question goes to Dr. Shananda. Your impression regarding the nutritional status of the child?
Hello. So ideally, at the time of PICU admission, we do a baseline nutritional assessment of any patient. So this child already had an NICU stay and had sepsis, NEC, was on antibiotics, and after 1 month the weight has not exceeded the birth weight. So the postnatal weight gain is also not good. So the nutritional status wise, the child is at high risk. And as we know, malnourished patient, they are already high risk. When they get admitted in the ICU, they have bad outcome.
Yes. So nutritional status assessment at admission and during the course of stay in the PICU is very important. This child, as we know, was of 2.5 kilos, but when she came to us, she was 2.3 kilos. And she was having a prolonged stay in the before she came to us. Has a history of NEC. So she is at risk of further aggravating, there are aggravating risk factors present in this child. So now back to her case. She underwent arterial switch operation of the VSD closure. She had a prolonged bypass time and surgeons were unable to close the chest. So shifted to our ICU with multiple inotropes, adrenaline, noradrenaline, vasopressin. Had a stormy course. She remained sedative, paralyzed, inotrope requirement increased, multiple blood transfusion, re-exploration was done due to severe bleeding and shifted back to ICU. But the baby remains, unfortunately, nil by mouth for the last 3 days. So is it, can we feed this child? What are the energy requirements and what are the macronutrient requirements? Over to Dr. Shubhadeep.
This child obviously is very sick. Had a prolonged ICU stay, as you already described. Chest open, and then a prolonged bypass time on multiple inotropes. Now, often this idea creeps into our mind that a child on multiple inotropes, whether we should feed the child, and it stems from the idea whether the splanchnic circulation will be hampered or not. But so far the evidences go, even on very sick children on multiple inotropes, if their hemodynamic is stable with multiple inotropes, even patients on ECMO, they can be fed. So yes, enteral nutrition, starting enteral nutrition early is very important. And even if we cannot build the entire nutrition, at least starting them on some trophic feeds would be very important. Regarding how much calories to provide these children, ideally in the acute phase, not to exceed the resting energy expenditure, and then once the child is coming out of this acute phase, once we are tapering the inotropes, once the chest is closed, and once we are coming out of the ventilatory support, then the nutritional requirements should also account for the rehabilitation, the nutritional build-up, the growth of the child, and the activities. What was the other question?
Yes, so macronutrient requirements of the child.
Yeah, regarding the macronutrient requirements, initially we usually start children on some amount of glucose Obviously, glucose cannot prevent the negative nitrogen balance, but at least we should make sure that the child does not go into hypoglycemia, and the hyperglycemia is equally dangerous. And we should provide them with some amount of protein, around 1 to 1.5 gram per kilo per day, to prevent negative nitrogen balance.
Yes. So, it's critically ill children through different feed formulas like polymeric versus semi-elemental impact on clinical outcome, Dr. Shanmugha. Regarding the type of feeds that we offer.
So when we start infant feeding, we usually start with the polymeric formulas. Most of the critically ill children tolerate the polymeric formula, but children who do not tolerate, for them we use a special formulas which are peptide-based formula, elemental feeds and all.
Yes. So these peptide-based formulas, they are like given for special set of children, like who are having feed intolerance. But they are seen on the like they are shown to increase 10 times the cost of the hospital stay, the hospital stay. So we prefer to start with polymeric feeds, and then we might change to peptide-based formulations if there is feed intolerance. Now back to our child. It was a post-operative day 3 and inotropes being tapered, but the child developed renal shutdown, peritoneal dialysis started. Feeds where are we? Yes. The nurses noticed that there are increase in pre-feed aspirates. What's next? Can we feed this child, or can we stop, or can we increase? Like, what's the opinion, Dr. Shubhodhi?
See, I do not routinely do NG aspirates if the child is on NG feeds already. So there are multiple reasons why the child can have pre-feed aspirates here. The child has been started on peritoneal dialysis, so we are giving a lot of volume in the abdomen, and that can increase your pre-feed aspirates. At the same time, the child is sick, so the tract motility can be poor, so that can also increase your pre-feed aspirates. What we simply do, or what ideally we should do, I think, is before every feed or after every feed, we should clinically examine how the belly is, whether the belly clinically looks ominous, if the belly is soft, can we hear bowel sounds, and then if we have concerns, and then you also monitor the abdominal curve. And if the abdominal curve increases by more than 2 centimeters before a feed, then yes, it would be prudent to do NG aspirates. When I would be concerned is NG aspirate if it's obviously bilious or there is blood stained NG aspirates. Otherwise, here in this case, I think we might as well add some prokinetics. Usually in children we would add metoclopramide, something like erythromycin, and if the abdominal distension settles down, we can continue either with the same feeds or when gradually build up the feeds.
Yes. So there is no evidence to suggest that either continuous, So like as Dr. Shubhodhi was said, that regarding the pre-feed aspirates, we don't go by we don't ask nurses to aspirate before each feed. Rather, we monitor the child clinically. Now regarding the type of feeds, like whether you would prefer to have a continuous or intermittent bolus feeds. So what's your opinion regarding that?
So again, evidence shows that none is superior than the other. So we can so bolus feeds, continuous feeds. It depends probably on the institutional practice and what is one more comfortable with. Generally in our unit we do bolus feeds rather than continuous feeds. Regarding post-pyloric feeds, typically that is something which is done in children who require a lot of interruption of feeds because of different procedures, like somebody is undergoing some anesthetic procedures. So those are the typical situations where post-pyloric feeds would be required, or somebody who is having a lot of GERD or reflux problems. So those would be another situation where post-pyloric feeds can be considered. But otherwise, bolus feeds, continuous feeds through NG would be probably equally efficacious.
Yeah, so this part has already been discussed, but Dr. Shanmugha, what's your opinion regarding gastric residual volume measurement?
So historically, there has been in the ICU, there has been a practice to do a gastric residual volume and gastric aspirate, though there is really no evidence for that. But recently there has been a trial which is showing that there is no role of gastric residual volume, rather on the contrary, it can delay the feeding, enteral feeding, and interrupt the enteral feeding, and it can cause nutritional inadequacy in the patient. So the main purpose of doing gastric residual volume is, it was thought that delayed gastric emptying can cause increased residual volume, and that can cause aspiration and pneumonia. So that was the logic behind it, but really the gastric residual volume consists of not only the gastric volume, the gastric secretion as well. So currently we don't routinely do that. We rather focus on the distension. Clinically we observe the child and if at all aspirate, whether it's bilious or blood stain, that is more important rather than the actual volume.
Exactly. And what about the role of prokinetics? Do you think prokinetics impact on clinical outcome? Though there is like yes,
It is used in lot of units, but I don't think there are
evidence based, like
Yeah,
evidence is for
yeah.
supporting its use. Yes. So back to our case, we are post-operative day 4, inotrope stopped full enteral feeds, but unfortunately on post-operative day 5, the child develops fever, tachycardia, abdominal distension, and this time bilious aspirates. So we suspected NEC, and the child was made nil by mouth. So what about the nutrition? Dr. Shubhadeep, what do you think? Do we go in for parenteral nutrition, and what's your practice guidelines?
So, right at this point of time, I don't think I would do any knee-jerk response. I would rather wait. I would give rest to the belly, antibiotics, and probably it would be safe rather not to start total parenteral nutrition for about 5 to 7 days. Rather just maintain the child on fluids. If need be, maybe partial parenteral nutrition with an amino acid so that the child does not go into negative nitrogen balance. But it has been shown in several studies that if total parenteral nutrition can be delayed for at least like 5 to 7 days, does not harm the child at all. And in fact, the chances of sepsis, the chances of prolonged ICU stay, those kind of would reduce. So I would avoid TPN right at this point of time.
Yes. So this is like the large randomized control trial, the PPANIC trial, which says that with reference to this, like if delaying parenteral nutrition for a week is associated with a good outcome rather than giving it early. So the post-operative day 6, and we have the child with improved hemodynamics, afebrile, abdomen soft, bowel sounds present. Our surgeon is happy to restart feeds. The baby was started on trophic feeds and progressed well. So that's the end of the story. And so the take-home message is that we have to start early. At admission only, we have to assess the nutritional status of the child. We have to know that we have to start early, and we have to progress fast. No need to measure gastric residual volume, but we have to go clinically, palpate the abdomen, see whether the aspirates are bilious or they are blood stained, how are the bowel sounds, and progress fast to achieve the full feeds for the child, and minimize interruptions and achieve the targets quite quickly. And definitely, we will be benefited if we follow our feeding protocol. Thank you.